Welcome to Collab Conversations, the podcast where impactful discussions serve as catalysts for change. I'm your host, Sabrina Hanna, and this podcast is dedicated to advocacy and the individuals driving positive transformation in the Canadian healthcare landscape. Within these episodes, we explore the indispensable role of advocacy, bringing to light stories that are frequently overlooked and applauding the relentless endeavors of those championing a more robust healthcare system and a healthier future. This episode's guest is Eva Villalba, the Executive Director of the Coalition Priorite Cancer au Québec, a patient advocacy group dedicated to improving the Quebec healthcare system for people affected by cancer. Since 2008, she has been involved in healthcare charities, advocacy groups, and nonprofits. She graduated from McGill University with double majors in psychology and applied linguistics, then completed an MBA from HEC Montréal in order to apply best business practices to the not-for-profit sector. She has completed a Master's of Science in Healthcare Transformation at the UT Austin Value Institute for Health and Care, with the goal of sharing value-based healthcare, VBHC, expertise in Quebec and Canada. Eva is passionate about good governance, government relations, public policy, community impact, healthcare transformation, and social innovation. Thank you for being here, Eva. Before we jump into the conversation, let's settle once and for all, how do you pronounce both your first name and your last name?
Eva Villalba.
Okay, everybody, you heard it straight from the goat's
It's been
mouth.
butchered so many times.
It's
And there's
Eva.
not that many syllables. Eva Villalba. Yes, thank you.
Perfect. All right, now that we got that out of the way, let's set the stage. Why is it important to shift the conversation from cost to value when it comes to innovative medicines, particularly in the context of diseases like cancer?
So if we look at our current healthcare systems, they're not actually healthcare systems. They're more sick care systems. And if we look at the incentives or what we actually prioritize and measure, we're actually measuring healthcare services. We're not measuring health. And so a value-based healthcare approach is actually a way to base our decisions on what creates more value for patients. And we'll talk about it in a second. So basically, right now we're encouraging volume of services. How many people are we seeing? What are the delays? How can we see more people? We're not actually seeing, are we doing the right things to the right people at the right time? And so a value-based approach actually encourages access to innovative treatments. It actually encourages giving the right treatment at the right time. I think it's essential for a precision-based medicine to be actually accessible to patients, because right now we're taking a very narrow-minded approach about like cost only and volume. And we're making poor decisions. We're spending less on something that looks less expensive, but will generate hospitalizations, complications, but it's not my problem, so I don't care, is basically, the different people's different silos kind of objectives about it, right? So I think that this value-based approach will actually enable us to say, okay, how do we improve outcomes for people over the entire trajectory of care, not just at the hospital? How do we make sure that they're the healthiest way possible so that they don't need to use our healthcare services? And that makes so much more sense in a public healthcare system. Sorry about
So
that.
I find, like, when you say making poor decisions, that is like, actually, it's so important because we are making poor decisions. When we think about HTA, when they're looking or they're reviewing a product and they're looking at the cost, but they're not thinking long term about, well, what value does this actually bring into the healthcare system? So why do you think like this hasn't caught on earlier? Why isn't HTA or regulatory or everybody who's involved, PCPA, why aren't they thinking about this value when they're doing those assessments? And maybe it's like we're really jumping ahead into the conversation, but
No, I
okay,
think we
answer
can.
that and then we'll go back.
Yeah, I think the answer is actually so annoyingly simple. I was having a conversation today with someone from government, and I said, look, I'm going to drop the mic, okay? I'm going to simplify the problems of our healthcare systems in one sentence. And that is, The reason that our healthcare systems are broken is because we have misaligned incentives. I'm going to explain what I mean by that. Doctors and hospitals get paid for the volume of work that they do, not for doing the right thing. Okay, so right now we're not actually encouraging doctors and hospitals and healthcare systems to create better health so that people don't have to go to the hospital. We actually have this whole system and we keep it running by performing more surgeries and giving more treatments. And even if the treatment only works for 30% of people, we're still going to start with that because it's a standard of care. So everybody gets it. You get a chemo and you get a chemo and you get a chemo. Everybody gets the same chemo. It's a very terrible Oprah's like sweepstakes, okay? What we really want is the 30% that it's going to work for, let's give it to them. And then but the second option might cost a little bit more than the first option. So we're going to fool ourselves into believing that the first option that only works on 30% of people is cheaper on paper, but it's not cheaper if you're taking your money and you're flushing it down the toilet for the 70% that it doesn't work for. And so that's a shift in mindset. And if you look at, a doctor, I got knee surgery like not too long ago, okay? If the doctor had operated on my left leg instead of my right leg, they would still get paid. Okay? There's no they're the payments and the reimbursements are not tied to outcomes. And so there's no actual motivation to deliver better performance like there is in the private sector for, if you're thinking about like Amazon or buying a new house or buying a new car, like there's some kind of consequence for not doing the right thing and for not delivering good performance. But there's none in the healthcare system. The incentives are really poorly aligned. And so in a public healthcare system where it's our taxpayer dollars, we're the clients and the users, right? So like we're paying for it and we're also receiving the care. We should want to invest more in preventative care, in population care, in early screening and diagnosis, in awareness campaigns, because that will cost us less than paying for people with advanced stage cancer or other diseases. But that's not what we based our decisions on. What we based our decisions on are, yeah, let's not spend money on prevention because we don't see the immediate impacts of that. So let's just spend money on the big shiny thing like an MRI machine or, you know, drugs or whatever, but not worry about the consequences of that. And now that we have limited resources, that's when we're really starting to think, and I think that the pandemic also made us reflect and realize how fragile our health systems were. And that's why, I'm also the co-chair of the Resilient Healthcare Coalition. And one of the ways that we build more resilient healthcare systems is by making them create value and by having data that follows the patient and by actually keeping our governments and healthcare systems accountable to delivering health and not just healthcare services. And right now, the only thing that we're measuring and rewarding is volume at the lowest cost, not value. Once you start thinking about value in terms of what are you getting for your money and not just how much does it cost, then it starts to change the whole game. And I think that's what we need to start going towards. It'll make us a lot more resilient in the face of, lots of unpredictable things. This is maybe not the last pandemic we have. We have an aging population. That's just not, it's not just going to affect how many people are in the hospitals, but it's also going to affect how many people are retiring. And so we're going to have less healthcare workers. So we need to kind of manage that. So in value-based healthcare, the basic equation of like what is value, because there's many people have different ideas of what it means. So let's clarify that from the beginning. Value is equal to the improvement of health outcomes for the patient. So that's clinical outcomes, but also patient reported outcomes. I would include patient reported experience in there as well. Relative to or over, if you want to imagine when you're back in high school and you have a nominator on top, that's the improvement of health outcomes. And the denominator on the bottom is costs over the entire trajectory of care. And that's value. Now, it's not an absolute number. It's more of a relative number. It's more of an idea of, does this give me more value than that? And when I talk about costs over the whole trajectory of care, that's a paradigm shift too. Currently, and I know that you work a lot on precision medicine, Sabrina. So I think that this is an absolutely necessary paradigm shift and cultural shift in order to actually enable that access to precision medicine. Because what we need to do is look at, oh, well, that diagnostic test looks like it costs a lot, and that precision drug looks like it costs a lot. But are we saving hospitalizations? Are we curing something that was previously fatal, and that person will go back to work and go back to their community and continue to pay taxes? Just to give you a metaphor and a parallel, in Quebec, we were the first ones to have subsidized daycare, and it's $7 a day, and it was very quickly shown that the government made money off of this like seemingly expensive program to subsidize daycares, because all these women were going back to work and paying income tax, and they're actually making money off of this program, and now the rest of Canada is doing it. So likewise, that's a very value-based approach. It's like, oh, well, it looks like it costs us a lot now, but we're getting so much more, and it's actually good for our communities, it's good for the people using it, but it's good for our whole society. And that's what value-based healthcare is. In the context of health, is let's just make better decisions earlier on so that we can avoid the consequences of giving people the wrong treatment or giving people things that look cheaper but then end up being terrible. To give you another metaphor, imagine that you have the choice between a clunky, crappy car that's like 20 years old or a new car, and there's like a $10,000 difference, $20,000 difference, but one of them you're going to crash. It's like, well, is it a good deal? Like, I only paid $10,000, but then I ended up crashing my car, not being able to get to work, broke my leg, or whatever it is. So that's basically the choices that we're making now. Is like, let's just hope that it works out, even though we know it's cheaper. It might not give us the results that we want, but there's no incentive for results. And that's the cultural change that we really need to demand from our healthcare systems as patient advocates, is like, not show me the money, but show me the results. Like, how do I know that my doctor has good results? Right now we don't, and I think it's going to take us a while to get there. But in places like Europe, or even in the States with cardiology, at one point with children in pediatric congenital heart problems, a lot of people were dying, and they were like, yeah, it's normal, like this is a really terrible congenital disease. And then they were like, wait, but at this other hospital kids are surviving. How is that? How could that be? And it's like, well, once you actually measure results and you figure out what's working well, then everybody can do it. So anyways, I think I talked for too long about this, but it gives you an idea of what we need in our healthcare systems. And the first thing is we need to demand that we make decisions based on, are people actually doing better?
Well, there were so many questions that I was going to ask that you already answered. So, but I want to go back on a couple of things. Hopefully I'll remember them all. So you talked about prevention, which I think is really interesting, because when we talk about our healthcare system, and I think I'm gonna paraphrase Louise Binder a little bit. She always says it's not a healthcare system, it's a sick system. So if we did actually focus on the prevention, then we might actually have a healthcare system.
Yeah, I mean, I like to say that, and I have heard this a couple of times, but it's I didn't make it up, but it's more of a, what we aim for with a value-based healthcare system is a predict and prevent model to replace the break and fix model. That's what we have today. We have this break and fix. We don't deal with it until it's broken. And then it's much harder. It's much more expensive for our system. Treating an advanced cancer is so much more expensive than treating an early stage cancer. And yet we still wait for that. We should be investing so much more in early detection and prevention. But that's not what we're doing. So yeah, I think you're right. And that it's because of we don't have incentives to do anything differently. But we do if we think about it, because we're the ones paying for it, and it's costing us a lot. It's not sustainable.
We have a lot of incentive. We, as in patient advocates and the patients and the patient communities that we represent, but government doesn't seem to have that incentive. And it seems like they talk a lot about like the cost of the drug, but they don't talk about like all the other costs within the healthcare system. So we focus a lot of our time talking about the cost of the drug, but that has always seemed like a problem for me. And so how does this value and I don't want to say value-based healthcare, but like this value perspective, how does that change that?
Yeah. So first of all, in the whole pie chart of all the things that we spend money on, medication is like a small part of the pie, but that's the one that always takes the blame. And I'm not saying that, we do need to make, access to medication more affordable, more accessible. We need to find ways to, mitigate that explosion of costs. I think one of the ways that we can do that is another value-based approach, which is called outcome-based agreements. It's not for everything, but for rare conditions, so that's either a rare cancer, a rare disease, or even a rare condition like uh, a rare mutation in a more common cancer, like an NTRK fusion gene mutation in a lung cancer, which is not considered rare, or a small cell lung cancer, which is more rare than regular lung cancer, and then with a ROS1 mutation that makes it extra rare. So anything that's rare, um, it makes a lot more sense to only pay when it works, which is basically what an outcome-based agreement is. It's like, you know what, this thing costs a lot of money. There's a high level of uncertainty. I'm not sure if I want to pay for it. Well, the way to get public and private payers to pay for that is to say, okay, well, I'm so confident, like that it's really worth this much. But since you have a high level of uncertainty, why don't you only pay when it works? Or pay less if there's a complication, or there's many models that you can apply it to. But basically, that's one way of ensuring that you give access to patients that need it, because usually the people with rare conditions have poorer prognosis. They do less well. It's never their turn for clinical research. It's never their turn for access, And so this is a way to really help those people and make it more equitable. And it's a value-based approach because it actually pushes people to deliver on outcomes. It pushes the manufacturers to only get rewarded when it works. Now, that addresses the issue of like how much does the medication cost, but you know what costs us even more than medications is how much we pay doctors, and nobody cries about that. Okay, so why don't we actually look at, are we
And they
really
deserve
using,
it.
yeah, it's not that they don't deserve it, but we don't even question ourselves, right? So like, I'm not saying not to pay doctors. I'm saying, are they actually being used at the top of their license all the time? Or are there certain tasks that could be delegated to other professionals? Because we know we don't have enough. So it's not like they're going to run out of work, but could we actually treat more people while still spending the same on doctors? And then everybody else is in another kind of budgetary line, right? They're like the hospitals and the everyone, like the nurses and all the different allied healthcare professionals. They all get paid in a different line, but of the budget. Um, how can we actually make sure that we're optimizing all of those healthcare professionals and all of those costs, like even operating rooms or MRI machines, imaging of other kinds? It's like, are we really getting our money's worth? Well, if you run it 24 hours and you run it in the middle of the night as well as during the day, then you're getting more bang for your buck for that machine, for example. Like another example is the Da Vinci robots, for example. So like it looks like it costs more than having a surgeon cut you up, except that when you use a Da Vinci robot, let's say for a urological cancer like prostate or bladder cancer, you actually have better outcomes. The patient is not impotent. They don't have erectile dysfunction. They're not incontinent. They do better. They go back to work sooner. They don't come back to the hospital in the emergency because they have so that costs the system less, even though at first glance that equipment is more expensive than paying a doctor. The other thing is a volume question, and volume and expertise. So, there's always this question of like centralizing or decentralizing. Like, does everybody need to have an MRI machine? Does everybody need all the specialists? If you do a little bit of everything, you're not an expert in anything. And in order to get the best, uh, precision, the best speed, the best cost, and the best expertise, you need to centralize it. So for rare conditions in particular, you don't want to have a CAR-T center in every administrative region of the province. What you want is to have a couple of centers that do those few cases really, really well and that develop an expertise so that each time they keep improving. But if we had one in every cancer center, then you wouldn't have that expertise. The learning curve would be way slower and it would be patients that pay.
Yeah, well, I don't foresee that becoming a problem in CAR T anytime soon. But I'm glad that you brought up CAR T, because when we first introduced, and actually before we introduced CAR T into the Canadian healthcare landscape, um, I convened the group of stakeholders and I asked, like, why are we not trying to do outcomes-based agreements, especially in the pediatric population? And like 50 pediatric patients are going to need CAR T, let's say, across the first year that we implement it. And it was like, oh no, we can't do it. It's too complicated. So let's talk about objective-based agreements, OBAs. If you've heard the acronym and you're always wondering what it meant, that's what it means. So um, let's talk about it, and then let's talk about, like, where are we at with OBAs in Canada actually?
Right. So I was actually supposed to be in Edmonton tomorrow talking about this subject, but I'm not. So um, outcome-based agreements are have been used in Europe for a couple of years now. They are currently being used in the United States in the public sector with CMS, or Center for Medicaid and Medicare Services. So their public sector in the US. And there's some big advantages to it, but it's complicated. And you know what? Like, the government people that we have in Canada are not like the most innovative when it comes to like novel accounting principles. Okay, so it's just a different way of doing it. It's absolutely not the status quo. It does require more information, more of a data infrastructure, which we did not have, and now we're building it. So I think there's new opportunities to actually tie some of those data points together that are necessary to do more complex kind of agreements that, you need to go and get the patient reported outcomes, you need to get the clinical outcomes, you need to get the use and the reimbursement criteria, and you need to centralize that. So we actually have a project in Montreal and Quebec with Montreal and Vivo, where we're doing a demonstration project in outcome-based agreements. And we have industry stakeholders, we have government stakeholders, and we're trying to show that it can be done, because in Quebec, we need to do it at home before we believe anything can be done. But then hopefully it'll inspire the rest of Canada as well. I know that they're looking at it very carefully. We're talking to um, PCPA, the Pan-Canadian Pharmaceutical Alliance, and um, the ones responsible for negotiating these agreements. And I think that in the next years, we will see more of it. Now, when you first talked about it, there was no need. There weren't that many CAR Ts. But now that there's more and more coming, and we know that they have a huge price tag, but that they're for a very small portion of the population. At first, it was okay. We were just testing it out, and there was a lot we didn't know. For example, we didn't realize that in the cost, we didn't just look at how much the medication cost, but all of the hospitalization that was necessary to make sure that it worked. So now we have to build that into like our evaluation of it, right? So I think that today it makes more sense with CAR T therapy, because like any other kind of cellular therapy, or anything else that's like very complex, I think that if there's a high level of uncertainty, there's a small population and a super high price tag, it makes more sense to say, you know what, we're going to pay when it works, but when it doesn't work, we don't want to pay. On the other hand, we can't do that and also expect 95% discounts on the medication, because then we're never going to get any innovative drugs in Canada, and that's not good for patients either. So it has to be either like a very tight kind of negotiation like we currently do with drugs that are going to be for a larger number of people, or if it's a rare population, then you can do an outcome-based agreement, but you can't also ask for like an 80 plus discount, 80% plus, So I think that's something that we have to keep in mind. There is more openness. We really have to like be open to demonstration projects, not pilot projects, because pilot projects are doomed to fail. Demonstration projects have scaling up built into them, and they really have to be co-created with patient partners, patient associations, clinicians, researchers, industry, and of course, public and private payers, to make sure that they actually get to patients.
How ready are we to start implementing OBAs?
So I think that the first step has to be to develop really good health data infrastructure. Because if the data doesn't follow the patient, then we can't, it's very hard to do this. That's why it makes more sense to do it in like ultra rare conditions, because currently a lot of doctors are doing it by hand anyways. They're doing it manually for these ultra rare, like any rare disease things. Or in Quebec, we already had like 5 OBAs, but they were only for like super rare diseases. And doctors were doing it by hand. And now it's finally online. Um, but you can't ask them to do this like enormous volume of like extra work. So I think that the first step is really we need to ensure data infrastructure is there to make it interoperable across like data and functional silos so that the data can follow the patient and we really know that the patient is doing better. The second thing is that it's only just starting, and we have a couple of demonstration projects at the Quebec Cancer Coalition, one in colorectal cancer and one in lung cancer that's starting up soon, um, on how do we do value-based healthcare in oncology in Quebec, and it's going to be applicable to the rest of Canada. But one of the things that is not being done systematically is measuring patient-reported outcomes in real time and having that be in a searchable area, like in a searchable place, like the electronic medical record. The other big announcement that we got recently is that in Quebec, we're going to start with Epic as the electronic medical record. It's going to take years to get there. Um, but that's why, again, I think that if we just start with like the very rare things, we demonstrate, we show what the model could be, we show how to do it. And then when our data systems are ready, we can do it at a little bit larger scale. But I think it's really important to reiterate that outcome-based agreements are not for all conditions. We're not just going to do them for everything. I think that it only makes sense when things are rare, there's a high unmet need, and there's a high level of uncertainty. Otherwise, let's just go with the regular negotiation of. But I think that in general, and that's just for medication, but I think we need to make decisions based on what treatments we prioritize, what surgeries we prioritize, what interventions like psychosocial support, like prehabilitation before a surgery improves outcomes. Like let's invest resources, let's prioritize things in the trajectory that can actually improve outcomes. And that's a shift in the mindset that's based on creating value for patients. And it's going to be better for the whole system as well as just for patients.
So, how do we get to this place where we're creating that shift in the mindset and in the paradigm where we're considering a value, and we're not just considering value, the cost of the medicine, but we're taking into consideration the patient preferences and the patient needs and
Yep.
the proms and the prems, and all of that is playing into that.
So first we need to kind of, that's what we've been doing, is kind of influencing people into seeing the pertinence of having value from the perspective of patients drive all of our decisions. Um, and I think that the other factor is showing that this approach is not just good for patients, it's actually more satisfying and rewarding for the healthcare professionals. It makes better, it's a win-win situation for all stakeholders. So when you look at value from the perspective of patients, if that's your objective, everyone wins. But if you're looking at value from the perspective of payers or of healthcare providers or of manufacturers, then it's only good for them. And so showing people what that looks like in real life. Like, look, patients don't want an all-you-can-eat buffet of healthcare services. They just want to be healthy and they don't want to go back to the hospital. Okay, it's not like if you tell them, look, you can have anything you want. They're not going to be like, I want this surgery. It's like, no, I don't want surgery at all. I don't want chemo at all. Give me the thing that's going to work the best and that's going to avoid me going to the hospital. Who like dreams of going to the hospital? It's not Club Med. So what you really want is what's going to give you the best outcomes and get you out of the hospital and back at home playing with your dogs or cats or children or garden or whatever makes you happy in life, and out of the hospital. And I think once everybody agrees on that, then there's a paradigm shift. The other thing is we have to work. Value-based healthcare is not only about outcomes and costs. it's also about integrating care. And we don't talk about that enough. So we need to integrate care. Right now, we have data silos, we have functional silos, we have budget silos. It's like it's a silo fest, okay? And what we really want is to work together as real teams. That means that we don't see one part of the elephant at a time, which is what we currently do. Like the surgeon sees the surgical outcomes, and the oncologist sees the chemo outcomes, and the physio sees the physio outcomes. The psychosocial support sees the mental health issues. What we really need is for everybody in the team to be working together towards that common goal of improving health outcomes for patients based on what matters to them. Crazy concept. I mean, that it sounds like that's what our health system should be made on, right? Like based on, but it's not. And so if everybody works together with that common goal to predict and prevent and not break and fix, then people won't have to work as much and we won't have to spend as much money and everyone will be better. And it's just mind-boggling to me that we just woke up to this. Like it just makes so much sense. And so, yes, we need the data to follow the patient. So we need to actually work on our health data systems. We need to have a more integrated approach. That means we need to work differently because right now we're under the impression that we're working as teams, but we're really working as groups of people and not teams. They're intervening sequentially along the trajectory of care and not necessarily seeing all of the data all of the time to accompany the patient towards those common objectives. There is no recording of what does the patient want besides having cancer, not having cancer. They want to have children. They want to go back to school or to work. They want to run a marathon again because that's when they were happiest. Whatever it is, all of these goals are important. And that's also where patient preferences and all of that and patient experience comes into play. So what do we need to do? We need to agree that value for patients is value for everyone. I think that's step one. Step two is we need to get out of our comfort zones and actually not be afraid of measuring to improve because right now a lot of healthcare systems and healthcare professionals are worried about measuring as if they're going to be judged. That's like very outdated, perspective, but I understand. So we need to create a safe space and a psychologically safe environment for people to actually measure indicators and use that as an opportunity for learning and improving. And so now a lot of the projects that we're doing in value-based healthcare are based out of the quality department of hospitals. But it's really important to remember that value-based care is not just for the hospitals. I was talking about prevention earlier. A real value-based healthcare system, not just a pilot project or a demonstration project, a real value-based healthcare system invests more in prevention, invests more in early detection and diagnosis and primary care. It enables home care and psychosocial supports and all of the things that are currently underfunded because they actually avoid people staying at the hospital. They give better health. And that needs to be, and I'm going to be like super annoying and like stubborn about it, but we need to keep repeating that what we want is value for patients, and that means health, not health services.
Yeah, that's very true. Health versus health services. But I find it really interesting because you're talking about wanting to keep the people out of the hospitals and out of the healthcare services system. And it seems like, since the pandemic, like there's been this influx of people into the healthcare system and the healthcare system hasn't been able to manage it. So like now is a great time to like really put the pedal to the metal on VBHC, but we're
Exactly.
are we doing that? Do we have the appetite to do it? I mean, we're always talking about like people don't go to the ER, don't like go to see your pharmacist, but what are we actually doing to keep the people out of going to the
Yeah.
hospital?
So necessity is the mother of invention, and that's why I think it's a really great time and an opportunity right now to have this shift. And in Quebec, we have a new health reform, and there is a lot of value-based healthcare in it. And so I'm hoping to kind of, be an influence there, and I'm working on it. But I think that this is a great time because in the American system, they don't necessarily want to reduce the amount of people that go to the hospital because that's how they get paid. But in our system, where we, the taxpayers, are funding this, and we have limited resources, both financial and material and human, this is the right time to really keep people out of the hospital, but not keep them out of the hospital and not give them good health, but like actually make sure that they're so healthy that they don't need the hospital unless it's really, really urgent. And like last week we were having an event on avoidable cancers. There are so many cancers that we can avoid either through lifestyle changes or through environmental factors. Like skin cancer is 90% avoidable. Why has the incidence doubled in the past 15 years? Because we're not raising awareness, because we're not investing in prevention, because we're not talking to people about sun safety. You know, there's all we've made great strides in reducing tobacco consumption, but there's still like other pollutants and there's still pesticides and there's still all kinds of other environmental factors like radon that actually cause cancer and that we can act on if we actually invest in prevention campaigns, which are so much less expensive than CAR T therapy, for example.
Well, actually, that's a really great, not a segue, but like if we do talk about skin cancer, and skin cancer is like it does take a lot of behavioral change to get people to not want to have that nice golden tan in the summer, because yeah, you look good at that moment, but down the line when you're at the hospital and you're getting treated. But that's actually not what I wanted to. I didn't want to go there.
Well, avoid. I think, yeah, I think the avoidable cancers and what I my point about the CAR T therapy is that if we were to take the budget for to treat one person for CAR T therapy, and we were to invest that into a public health campaign to raise awareness about avoidable cancers, whether it be through HPV vaccination or radon detectors in every home, or actually holding polluters accountable and reinvesting some of that extra tax money into prevention campaigns. Like we could actually drastically reduce, and in France, they have an objective of reducing avoidable cancers by 30% by 2030. We don't have any such objective anywhere in Canada that I know of. And I think we need to give ourselves these objectives and then hold our decision makers accountable to delivering on them. So make different decisions. Have a predict and prevent approach instead of a break and fix approach. That will save us money. And it's not like we don't have unlimited money, but more importantly, we don't have the unlimited resources. Even if we threw money at the problem, like there's literally no staff for our hospitals. We don't have enough technologists. We don't have enough specialists. We don't have enough of a lot of things that we need. So it's not money that's going to solve the problem. It's a different approach based on value from the perspective of patients.
Yeah, and that was the point that I was trying to make with the skin cancer analogy, was like if we invested the money to tell people or to create that behavioral change, then there would be a lot less people. And there are a lot of skin cancers that are not, you don't go through and see your oncologist, but
Yeah.
you're constantly going to see your dermatologist because you're getting something removed.
And you're
And that
taking
is,
time off work, you're like not there with your kids. Like so many other impacts. And we just say like it's no big deal, it's just a little mole, but it is a big deal. And how do
yeah,
you know the difference between like are you going to get the cancer that kills you, or are you going to get the other cancer that just disfigures you? You know?
yeah.
Are they
So
better really? Like no, like if we know how to avoid it, then we should really work on raising awareness for how to avoid it.
So then does prevention also, is that also an approach in value-based healthcare?
Of course, it's doing the right thing at the right time to create the best outcomes for patients. So we should be investing more in a population approach. We should be investing more into things that don't aggravate or don't cause people to get sick and use the healthcare system. So yeah, that's the population approach to value-based care.
And it was interesting that you talked about how in France they have an objective to reduce the avoidable cancers. I think you said 30% by 2030.
Yeah.
And in the US, with their moonshot, they have the objective of reducing all preventable cancers by 50%, I think, by 2030 as well. So,
Yeah, no, theirs was even more, ambitious. It was, let's reduce the mortality of cancer, all cancers, by 50% in 25 years. So they're giving themselves more time, but it's a way more ambitious objective. One of the ways that they're doing that is by investing massively in clinical trials. But, another really interesting kind of objective of the 10-year cancer plan in France is, let's improve the prognosis of cancers that are known to have a poor prognosis, like, pancreatic cancer is the one that everyone thinks of, but a lot of the upper GI cancers, brain tumors, a lot of the more rare cancers, they have a really poor prognosis. And because they're rare, it's never their turn. There's a lot less clinical research. They don't have as many treatment options. And so France gave themselves this objective, and it basically forced them to invest more into these, understudied cancers to find better options. And so that's what we need, is we need measurable, ambitious objectives that will guide our decisions, that are value-based, that will actually aim to improve the lives of people affected by cancer. And by doing that, we're going to use less healthcare resources. So it's going to cost us less, and we're going to have a more resilient healthcare system. And so it all goes back to, what are you basing your decisions on? And right now, we're just doing the same old, same old. We're just looking at cost, we're looking at volume, and it's like we haven't learned our lesson, you know? We're not actually saving money. We're spending more. It's like when you buy clothes on Shein, how long do they last you? It's like the cheap clothes that lasts like 2 times, and then you have to buy it again. And is it really better than buying one good quality thing that you'll have for 20 years? Like, I still have stuff in my wardrobe that's like from the 90s, Not that it fits, because obviously I'm not the same size, but I'm the same height. So that helps.
I love these analogies so much. So I don't even want to walk away from that, but I want to go back to, you were talking about like data following the patient. And I mean, I like to go back to COVID because we did so many things well. And we had like these dashboards that were telling us every single day, like in Quebec, so many people contracted COVID, so many people died. Like these are the hot spots of where there's a lot of COVID cases right now. And why are we not able to do this with cancer?
Exactly. So I wrote a lot of op-eds on exactly this topic. It was frustrating. It was encouraging to see that all the reasons, all the excuses that we got from the excuse factory of why we couldn't do anything, like, oh no, we can't actually measure that, or oh no, we can't do, virtual consultations with patients. And then lo and behold, during the pandemic, we were able to do all of these things that we said were impossible to do. So, it shows us that bureaucracy is really holding us back, not our ability to do things. There's like innovative solutions for everything. The question is, do we want to do it? Do we have the political will? And are we going to prioritize this? Yes or no? So COVID showed us that. The second thing it showed us, and especially in Quebec, I really loved the public facing dashboards that they had about how many people have COVID, how many people are vaccinated, how many people are vaccinated in each hospital, in each region, what is the rate of vaccination, how many vaccines does everyone get? I mean, it was incredible how much data we had. One of the reasons was because for the first time in a long time, we got a non-doctor minister of health. And as a business person who was humble enough to admit that he didn't know everything, he was like, well, how do you expect me to evaluate like if this is going well or not? Like, show me the data. Where are the numbers? And they were like, we don't have any. And he's like, okay, you better fix that like now. And so he put a lot of pressure on the system to actually deliver, and he had no patience for everybody's usual excuses. I mean, in Quebec it took us 14 years to have a freaking cancer registry, okay? It makes no sense. There's no like physical reason why, there's no good reason why it took us 14 years, right? Like it's just excuse factories all over the place. So COVID did teach us that we could accelerate things, yeah, whether it's access to vaccines or medications or, you know, doing things differently. We started vaccination clinics. I mean, you know, my sister was running the vaccination clinic at the Olympic Stadium. It was incredible. It was like 3,000 people a day were going in and out, getting vaccinated. We were able to do things that we never thought. So that was a resilient approach. That was like, okay, we have to do things differently. The way that we did things before wasn't going to work. The other thing is the data. We saw the power of having data in real time to make better decisions. That is crucial for a value-based approach. So in our demonstration project in colorectal cancer at the Jewish General Hospital, we're giving patients the ability to record their patient-reported outcomes on an online tool where they can say, you know, it's very short, it's like 8 minutes, and they say how they doing with pain, with mobility, with sexual function, with their mental health, with digestive function, et cetera, et cetera. And they get information in real time right away to help them. If it's like a serious symptom, a nurse will call them in 24 to 72 hours, 2 to 3 days. That's amazing. And give them kind of some support. And then by the time they see their doctor or nurse again, that doctor or nurse sees how they're doing based on their own reporting, but also the previous reporting. So they see the trends. Is this getting better? Is this getting worse? Do we need to prescribe, you know, diuretics or, you know, something else to help with the sleeping or with the whatever, right? That is responding in real time. And it's incredible that in our healthcare system, we don't currently make decisions on data, based on data. We're literally guessing based on what we assume. And you know what they say about assuming, right? It makes an ass out of you and me. So we do not want to assume. What we want to do is based, you know, we talk about evidence based in medicine. We need to have data driven prioritization and this and political decisions. Where do we put resources? Is one hospital overfull, but we can actually send the patient, you know, 20 minutes, 30 minutes, an hour drive. I mean, it takes me an hour and I live in Montreal to get downtown, you know? So like if I go to another city, which is 30 minutes away from me, but it's off the island of Montreal, and they can take me for my day surgery, let me go there, you know? And so we need data to make those decisions, to make better decisions, to allocate resources better. And I think that now we have a new law, the Law 5 that just passed last year. It's going to be effective now in April. And I think that with that law, we are setting up the foundations to have more interoperable systems where the data can follow the patient. And if the data follows the patient, then we can do all of the other value-based things. Then we can make decisions based on real needs, based on inequities, based on, you know, where the resources exist. And so I think that that's very promising. But COVID did show us that having the data in real time allows us to make better decisions and allocate resources better.
And are there examples or success stories where value-based healthcare has been implemented and has made a tangible difference?
Yep, sure. So I'll give you a very good one that there's an article published on it. So in Belgium, there was an oncologist who used patient-reported outcomes in real time with a kind of trajectory mapping system. And they were able, with metastatic lung cancer patients, to improve the overall survival from something like 148 days to 253. So it was like over 100 days extra overall survival just by measuring outcomes in real time and responding in real time. There are drugs that don't do that. Okay. So that's number one. Number two, they were able to reduce emergency room visits substantially, I think by something like 40%. And the third thing is they were even able to reduce the time in ambulatory or outpatient care for those patients because a lot of their answers were answered remotely with this system. So that's 3 very tangible, incredible results that you would not get if you were just continuing with the status quo. And so we're actually bringing it to the EUCPQ, the Lung Cancer Institute of Quebec City, this year. And so we're going to be doing it on lung cancer as well. So there's really great opportunities. We know that it works. It's better for patients. It's also better for the teams, like I mentioned. The teams actually enjoy having data to make their decisions. If you ask a doctor now, like I work with this doctor that treats a lot of glioblastoma or brain cancer patients, and the patient was like, okay, doctor, you just presented your options to me for treatment. So tell me, how have your other patients done that have done this treatment? And he was so frustrated to not be able to answer her because even doctors don't have access to the outcomes of their own patients that they're treating. They're like, okay, well, I gave them this. I know what I gave them, but I don't know how they did afterwards, you know? And so a real value-based approach would allow a doctor to say, and they're doing this in the Netherlands already, at the Santion hospitals, they're able to say, okay, Sabrina, you have these 3 treatment options. Now, for a woman of your age, in living where you live, who has done option A, they usually got more nausea. But with this other treatment, you get more fatigue. And this third one, well, it knocks you out, but then you get to go back to work much quicker than the other ones. So what's important to you? And then you get to choose based on other people like you. That's amazing, but you need to have the data, and you need to be they can do it because they've been collecting patient reported outcomes for a long time. So another, essential step apart from, having that enabling IT infrastructure and the data following the patient is that we need to systematically start measuring patient reported outcomes, and that's not something that's being done yet, but I think that's where patient advocates are really lobbying for that to change.
I feel like I could just like have this conversation with you for a long time more, but I'm going to try to wrap it up a little bit. So, looking ahead, what do you foresee as the trajectory of value-based approaches in cancer care or like in healthcare in Quebec and in Canada?
So in 2019, when I did my first value-based healthcare course, and actually I will give a shout out to Louise Binder, who had a really great, I think it was the first or the second Patients Redefining the Future of Healthcare Summit, and she was talking about value-based care. And I thought that was super interesting. So I got interested. I went to Texas and I did my first course there with Elizabeth Teisberg, who's the mother of value-based healthcare. And my goal was to have Quebec be the leader of value-based healthcare as a culture, as a way of being, as a paradigm of the healthcare system, and not as yet another pilot. That was my goal. And I have to say, that ever since then, I've been very stubborn about, making sure to spread the good news everywhere and get more and more allies, show that it can be done, and work with multiple stakeholders in the government, in private payers, public payers, with industry, with healthcare providers, with academics. I'm like relentlessly obsessed about getting everyone on this value-based healthcare bandwagon because I truly, sincerely believe that it's the way to create the healthcare system that we deserve. And that it's really the way to improve the lives of people affected by cancer and affected by all the other diseases that we can have. And so what the next step is already, like I mentioned, I think that the Pan-Canadian Health Data Strategy helps, that the Quebec Health Data Law that is in place and that will be effective as of this year is going to help. I think that the new healthcare reform in Quebec makes it so that we're actually going to be leaders. I really, I am an optimist, but I am contributing what I can to this endeavor, and I think that there are elements of value-based care healthcare. More and more, the healthcare system is looking for ways to do that. We have a learning health system. Also approach in Quebec, which I think is helpful. We really integrate patient partners at all levels of government, and I think that that's extremely complementary to the value-based healthcare approach. So I had published I had edited a report with 20 cents called Value-Based Healthcare in Canada, and you can find it on the 20 cents website. 20 the number and cents like common sense, and in there was a Venn diagram of like value-based healthcare, learning health systems, and patient partnership, and at the center is patient outcomes. And I think that that's why Quebec is really well poised. The former deputy minister responsible for health system financing was a very big fan of value-based healthcare. And so he had like a 5-year plan to bring us towards, those misaligned incentives that we were talking about at the beginning. How do we actually incentivize value by having these bundled payments, by actually incentivizing good performance of healthcare systems? And in the first years, he was looking at it in the hospitals, but very soon, within those 5 years, he was looking at, okay, how do we include paramedical services? How do we include like primary care in there? How do we include pharmacies? How do we include home care? And I think that's really going to make a difference. And hopefully, in Quebec, we're special and unique snowflakes because we have this vertically integrated kind of HTA system that makes us a bit more autonomous and independent. And we always want to do our own thing, but we're also pretty innovative and we take more risks. So I think it gives us this opportunity to actually be leaders in value-based healthcare. And I think that the Minister of Health right now, Christian Dubé, he really gets it. He really wants to perform, and he wants to perform for the right reasons. He doesn't just want to like cut funding. He actually wants to take care of people in a better way, and that's why he's a fan of value-based healthcare. And I'm hoping that it's going to continue in this direction. I'm definitely going to continue to train more people and talk about it as every opportunity that I have. So thanks for inviting me to have yet another platform to talk to about why value-based healthcare will save us all from another apocalypse.
Amazing. So actually, what I'll do is I'll link the
Yeah,
article that you mentioned in the 20 cents. I'll link it
yeah.
in the podcast episode. But to people who are going to listen and who are going to be inspired to jump on the value-based healthcare bandwagon, like what do they need to do? Like walk us through it. Like how do I help you like push this forward? How do other people get this happening in their provinces? What do we need to do now?
Well, I'm organizing a value-based healthcare summit in April in Montreal, bringing international experts. And I think that, patient advocates are going to be a really important voice. Healthcare providers are going to be a really important voice. I'll give you the link, but it's vbhcsummit.com. So it's pretty easy to remember. And it's going to be taking place in mid-April in Montreal. I think that just even having these conversations locally, it makes a huge difference. Starting to talk about value in a way that, is not pharmacoeconomic value or like money value, but really like, are people doing better with this intervention? You know, at a very macro level, everyone could actually do that. And like, if we don't have the data for it, why the heck not? Like, let's get it. Why aren't we measuring this? And so I think that we need to go towards this culture of measurement for improvement, not measuring to judge, but really like we deserve to know like how much do you use Google reviews? I'm a level 8 Google reviewer, by the way. So I review all the restaurants, the museums, anywhere that I go in the world. I have something like 4,000 Google reviews. Okay. We use Google reviews. Why? We have more information on restaurants than we do about our healthcare system. Is this not insane? We should have way more information about the services that we're getting. Are people doing better? And if not, then why are we still using this treatment from 20 years ago? Like there has to be a better way. So when you were talking about like HGA and like the drugs cost us a lot, like are we really using the best thing just because it's cheaper? Like, is it actually better than the new treatments that are coming now? Like, yeah, they're more expensive, but if I can get out of the hospital twice as fast not have to go back to the hospital after, then it's totally worth it. So that's where we're really talking about value versus cost, but we really got to just start even that reflex if everybody starts asking, but where's the value for the patient? Like, where's the data that shows that this is really the right decision? And does it really cost us less if we look at the whole trajectory of care? Or are we just being narrow-minded and like looking down in a very accounting way at like only this thing right in front of me right now and forgetting about the value that it brings?
Yeah, we're absolutely doing that especially in our HTA, where
Yeah.
we're just looking at what is this gonna cost and not thinking about bigger picture.
So in this edition of value-based healthcare in Canada, I interviewed Michel Deguise, Dr. Deguise, who is the CEO of Ines, and asked her about how Ines perceives value-based healthcare. It's a very interesting interview. It's in English and in French. And Ines is actually ready to start making evaluations based on value. So let's hope that CADIT/CDA, Canadian Drug Agency, actually now also starts making that decision. But they're a little bit more conservative than Ines. So I think somebody's got to do it first, and then the rest can follow. So like I said, I appreciate that in Quebec we're a little bit more innovative and creative, and we take a little bit more risks. But we also have this like solidarity. Ines is the only HTA that actually asks for the impact on the society and the community and the system. And so I think for that reason, value-based healthcare makes a lot of sense in Quebec. And I think that very soon, and there's some great examples. I mean, I know doctors in Newfoundland, in Vancouver that are doing amazing things in value-based healthcare. So it's not like it can't be done elsewhere. I just think that in Quebec we're a little bit ahead, just because we have all the right conditions in place, and also because the pandemic really hit us harder than everywhere else. And I think that forced us to adopt a novel approach as well.
Yeah, I agree. I think that Ines has been doing a really good job, especially when I first started, when we were a little bit behind what was happening in the rest of Canada. But I would say in the last like 5 to 7 years, there's definitely been a huge shift. So we've talked about value-based healthcare. We talked about setting objectives and having a national cancer plan. You talked about the value-based healthcare summit that's coming up. I know we talked about a whole bunch of stuff. Oh, we talked a lot about data and patient preferences, and you talked about your project at the Jewish. So, is there anything else that is pressing as a pressing issue for you, and that or areas where you think there needs to be more focus on in order to be able to advance and bring more value to patients?
I think I covered everything.
So a big thank you to Eva for coming on the show today and shedding light on the pivotal shift from cost to value in our conversations about innovative medicine. And it's not just about the price tag, it's about the value these treatments are bringing to the patients and to the system as a whole. I think we learned that today. So join us next time on Collab Conversations as we continue exploring the topics that are relevant today. Until then, stay curious, stay informed. Thank you, Eva.
Thank you.